All right, in this lecture, we're going to talk about leukostasis. So this will be a relatively quick lecture. We're just going to briefly talk about this pretty high yield topic that you'll see in hematology oncology, and you'll see on your board exams. And then I'm briefly going to break down acute myeloid leukemia versus lymphoma versus CML. I plan on doing a whole lecture on some of these hematological cancers. So we'll talk about those more in depth. This will just kind of be like a brief overview so you get a little bit of a taste, so then when we actually do the lecture, it's not just a complete like out of the blue. All right, so like I said, leukostasis, AML, lymphoma, CML, I'm putting it all together. So here's our case to consider. A lot of people got this wrong on Instagram, rightfully so. It was a tough question. So let's talk about it. So we have a 55-year-old man is brought to the emergency department by his wife due to progressive shortness of breath and confusion over the past 24 hours. He has no significant medical history and has not seen a physician in years. On exam, he is ill appearing, tachypnic, and disoriented to time and place. His temp is 98. Blood pressure is 130 over 76, heart rate's 112, respiratory rate 26, oxygen status 88 on room air. Chest auscultation reveals diffuse crackles bilaterally. Chest x-ray shows patchy bilateral interstitial infiltrates. His lab testing is notable for white blood cell count of 120,000 with 90% circulating myeloblasts. Hemoglobin and platelet counts are normal. Blood cultures are pending. Which of the following medications should be initiated immediately to address the underlying pathophys? Are we going to use something that inhibits NF-kappa B, something that inhibits ribonucleotide reductase, something that inhibits dihydrofolate reductase, or something that inhibits tyrosine kinase? So pause your screen, take a second, think about it, and then we'll discuss. So this patient is having leukostasis or leukostatic or static crisis. Hyperleukocytosis is another way you might see it. Basically, what is happening is this patient is having hypoxemic respiratory failure, as evident by his respiratory, his SpO2 of 88% and his diffuse bilateral infiltrates, and his white blood cell count is up over 100,000 with circulating myeloblasts, right? So this we can all put together. This patient likely has acute myeloid leukemia. So remember, to diagnose acute myeloid leukemia, we need to see over 20% myeloblasts on bone marrow, right? And we'll talk about this in a second. I think a lot of people thought maybe this was CML. Remember, like the myeloblasts point me more towards acute myeloid leukemia rather than CML, right? If I was going for CML, I would have maybe given you more metamyelocytes. I would have probably given you some basophilia. I could have told you the leukocyte alkaline phosphatase was low. And we'll kind of talk all about this when I do my own lecture on CML versus leukemia reaction. But really, this case is not pointing me towards a diagnosis of CML. The fact that this was a pretty abrupt onset points to more of an acute process versus CML, chronic myeloid leukemia. Most of those patients don't even know they have cancer until they come in for their regular screening PCP appointment and something is noted to be abnormal on their routine screen, their routine CBC. So this is likely leukostasis secondary to AML because we have the white blood cells over 100,000, we have the circulating myeloblasts, and they were 90%, and we have this acute hypoxemic respiratory failure. So what's going on in this patient? Well, it's microvascular obstruction by the blast, right? These big old blasts that he's got. He's got 120,000 white blood cells in his circulation and 90% myeloblasts, right? They're bigger cells. They're going to get clumpy and they're going to block up a lot of my microvasculature, okay? That can lead to tissue hypoxia, especially in the lungs and the CNS. What we do is we do urgent intervention with hydroxyurea. Hydroxyurea is a ribonucleotide reductase inhibitor because that's going to rapidly lower my white blood cell count. Okay, I've got a slide next where we'll dive a little bit deeper into leukostasis, but that's pretty much the gist right there. So incorrect options, NF-kappa B inhibition, there's a lot of drugs that do that. Maybe you're thinking steroids here, right? Because steroids do inhibit NF-kappa B. Steroids are going to take too long for them to like really kick in, and they're not first line, right? First line in the guidelines for treating this leukostasis as hydroxyurea, not steroids, okay? Dihydrofolate reduction inhibition, so that would be methotrexate, not going to be effective here. And then we have the tyrosine kinase inhibitors, which a lot of people probably picked that. That was the most popular answer because they were thinking CML. But again, tyrosine kinase inhibitors would be great for CML. CML is not going to lead to this leukostatic picture like we've got here. There is mention in the guidelines. Some of these acute myeloid leukemias can have this FLT3 or a similar mutation in which tyrosine kinase inhibitors could be effective, but for immediate treatment, first line for my leukostasis, it's still not tyrosine kinase. It's absolutely hydroxyurea. So our goal here with this treatment is to temporize the blast burden, lower that, and then so we can arrange for the induction chemotherapy to help treat this cancer so we don't progress to this leukostatic crisis one more time. If you want to read more on the hyperleukocytosis and leukostasis in acute and chronic leukemias, you can read about it here. So again, really I was pushing you towards acute myeloid leukemia when we see over 20% blasts. We see a white blood cell count over 100,000. We see acute hypoxemic respiratory failure. You should be thinking about AML complicated by leukostasis. I wasn't pointing you towards CML. I didn't give you a basophilia. I didn't give you metamyelocytes. This is more of an acute process. Tyrosine kinase inhibitors, even like it's an intriguing option if this was CML, but remember, tyrosine kinase inhibitors are not first line for leukostasis in AML, so I'm not going to give it anyways, right? I'm giving hydroxyurea, all right? So leukostasis, again, definition, life-threatening complication of acute leukemia with a white blood cell count over 100,000. Again, it's mechanical obstruction by these bulky, rigid blasts. We get endothelial injury from cytokine-driven activation. It leads to microvascular hypoxia, hemorrhage, and organ dysfunction. Classically, the lungs and the CNS are going to be impacted, so you'll see the bilateral interstitial infiltrates on the chest x-ray, and the patient could have headache, confusion, and focal deficit. Really, this is a clinical diagnosis we should suspect in symptomatic patients if their white blood cell count is over 100,000, right? We should have a strong suspicion. Again, treatment, one more time, rapid cytoreduction with hydroxyurea. We can use leukophoresis, which I'll talk about on the next slide, and then we'll start definitive leukemia therapy, and we can do supportive care. So again, just the goal of treatment, right? We're going to do rapid cytoreduction and aggressive supportive care. So hydroxyurea, hydroxyurea, hydroxyurea. It's a ribonucleotide reductase inhibitor. It is the first line for this. We'll usually use a dose of 50 to 100 milligrams per kilogram per day in divided doses. It's going to be oral and it's going to work ASAP. All right. We can do leukophoresis as adjunct therapy if the hydroxyurea is not cutting it. This is basically taking out the white blood cells out of the patient's blood and then giving back the red blood cells, platelet, plasma, things like that. So it's kind of similar, more or less, to plasmapheresis. In this case, we're taking out the white blood cells, okay? Take out those big clunky myeloblasts. Definitive therapy would then be, once the patient is stabilized, let's do the induction therapy, okay? We tailor it to the leukemia subtype. It's the only curative option. And in supportive care, we can do IV fluids. We can give allopurinol or rasburicase for tumor lysis syndrome prophylaxis. We can do transfusions, and we're going to try to avoid cranial irradiation, okay? The guidelines are really specific about avoiding cranial irradiation in patients with leukostasis. I will do a whole lecture on tumor lysis syndrome, so we're not going to talk about it here. But again, leukostasis, I think about a patient who's got over 20% blast. Their white blood cell count is over 100,000. They've got acute hypoxemic respiratory failure, and maybe they have confusion and neurological deficits. I'm immediately thinking leukostasis or hyperleukocytosis, whatever you want to call it. I'm going to start them ASAP on hydroxyurea. If they already give me hydroxyurea in the vignette, or if this is real life and the patient's not responding to hydroxyurea, what would my next step be? It would be to start leukophoresis. All right. This is just brief. Again, the whole point of this lecture is to not cover these in depth, but I wanted to just give, because we've talked about them, what are the differences really briefly between AML, lymphoma, and CML. So AML is going to be more of an acute onset. We're going to have fatigue. We're going to have infections. We could potentially have bleeding and pancytopenia. And then there is an AML, APML, acute promyelocytic leukemia, that is associated with DIC. I talked about that in one of my previous lectures, and I'll probably talk about it again when we do our other hematological cancer lecture. So the onset is really quick in AML, days to weeks. We usually see it in older adults, usually around 65. Pathophys, we get clonal proliferation of myeloblasts and a maturation arrest, okay? So the myeloblasts aren't able to progress. We will see the myeloblasts again in APML, with the 1517 translocation being the most common. We can see these hour rods, and then we can see pancytopenia. Again, to diagnose this, 20% blasts on the bone marrow, hypercellular bone marrow. We can diagnose with CBC, smear, bone marrow biopsy, flow cytometry, and cytogenics. For lymphoma, remember there's two major flavors of lymphoma. There's Hodgkin's and non-Hodgkin's. We'll see painless lymphadenopathy, our B symptoms where we see fever, night sweats, weight loss. This, as opposed to AML, lymphomas are more subacute to chronic, over weeks to months. We see a bilateral where Hodgkin's loves to impact younger adults, and elderly would be more of the non-Hodgkin's. The pathophys is going to be a clonal proliferation of the lymphocytes, classically more B cells than T cells. The peripheral smear is often normal, or we might see lymphoma cells in the leukemic phase. So remember, like in CLL, we could see like smudge cells, and in Hodgkin's lymphoma, we can see those Reed-Sternberg CD15, CD30 cells that look like owl eyes. The bone marrow, we're going to see lymphocytic infiltration, nodular and patchy. We can do excisional lymph node biopsy, and then PET-CT for staging. CML, again, like I told you, it's often incidental. You might see fatigue, splenomegaly, early satiety, but really the patients are often asymptomatic. It's a chronic and insidious course, right? The adults are 30 to 60. The problem here is clonal proliferation of mature myeloid cells driven by this Philadelphia chromosome, the BCR-ABL, that T922. We can see leukocytosis with the left shift, the basophilia, and the low LNP. Again, I'll talk about this more in my lecture, but they love to discuss or make you decide, is this CML or is this a leukomoid reaction? A leukomoid reaction is just a strong white blood cell response to an underlying infection or another malignancy. And in that case, in a leukomoid reaction, I'm able to produce a lot of my mature white blood cells before I have to shift over and do that left shift where I'm pumping out as many of my premature neutrophils as possible to try to take care of the problem. In leukomoid reaction, right, because the vast majority of my white blood cells in circulation are going to be mature, they have a large amount of leukocyte alkaline phosphatase. That is a enzyme found in mature white blood cells. So the LAP level is going to be high in a leukomoid reaction. In CML, the LAP level is actually low because what's the problem in CML? We have a abnormal production of my mature myelocytes, right? Of my mature white blood cells. So in that case, the LAP is going to be really low because we don't have our mature myelocytes in the circulation. And if we don't have our mature white blood cells in circulation, they're not able to produce the LAP. All right. And again, I'll talk about this more when we do that lecture, and I'll compare them. Bone marrow, we could see granulocytic hyperplasia, less than 10% blast. We can do CBC, the FISH PCR for the BCR ABL, and we can calculate that LAP score. All right. Treatment really quick for AML, we can do the 7+3 regimen. So we'll usually do cytarabine for 7 days and daunorubicin or idarubicin for 3 days. What do I need to look out for if I start the patient on daunorubicin? So we're going to look out for HFrEF, okay? So my anthracyclines, maybe you know doxorubicin, right? Daunorubicin is from the same family. My anthracyclines are linked to HFrEF, so be on the lookout for that. We can do targeted agents. I'm not going to even try to pronounce these names, but if they have certain mutations, again, for step 1 and step 2, honestly, more step 2 than step 1, I would definitely know cytarabine and daunorubicin for my AML. If the patients are unfit or they're elderly, we can consider other options. Again, I just have these on here for completion. I would really want you to know cytarabine and daunorubicin or anthracyclines for AML. All right, lymphoma, we're going to use our R-CHOP. Again, another really high yield one I would know for going into your step 2 exam. So that's exactly what it sounds like, right? R is rituximab. C is cyclophosphamide. The H, the doxorubicin, right? So in the same family as what we just talked about, daunorubicin, it's an anthracycline. It used to be called hydroxydaunorubicin. Now it's called doxorubicin, okay? So that was the H. The O is oncovin, which is also vincristine, and the P is prednisone. So it doesn't work out totally, but it's rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. Do enough practice questions, put them on an Anki card, you'll have them pretty memorized. Um, we can do for Hodgkin's lymphoma, so that would be for like diffuse large B cell lymphoma, so a non-Hodgkin's. For Hodgkin's, we do the ABVD, so adriamycin, which is also another name for doxorubicin, bleomycin, vinblastine, and dacarbazine. All right. So again, I would take a screenshot of these, throw them onto an Anki card, have them memorized over a week, and then you're probably good to go. All right, and then CML, everyone knows CML, so really we don't need to get into it much here, but we're really going to use tyrosine kinase inhibitors. So any drug that ends in nib is probably a good bet, right? So imatinib, dasatinib, nilotinib, and bosutinib. Wow, man. Okay, and then we can do second or third generation TKIs for resistant disease. Again, it just ends in the inib, so just look for those. They could just say tyrosine kinase inhibition, or they could actually name the drug. All right. So if you want to read more, I have several different studies that I use to help put this lecture together. I had studies at the beginning when I did the leukostasis question that you can read too. And so you can take a screenshot, put that into Google, and now we'll put it all together. We have a 22-year-old African-American woman with a history of homozygous sickle cell disease. She presents to the clinic for routine follow-up. She reports that she has had fewer pain crises over the past year. She was started on a new medication approximately 8 months ago, and her laboratory results now show an increase in the MCV and elevated fetal hemoglobin levels. Her current medications include folic acid and a ribonucleotide reductase inhibitor. She has no current complaints. What's the rationale for initiating this therapy? So we took our ribonucleotide reductase inhibitor that I asked you about in the first part of this case, right? Where we have the leukostasis, it is the first line drug. Now I'm showing you another way we can use hydroxyurea, and it's in sickle cell disease, okay? So I want you to think about, why did we prescribe this hydroxyurea in this patient with sickle cell disease? What's the mechanism? So it's a pretty cool mechanism, and it's pretty much unknown. So we do know hydroxyurea blocks ribonucleotide reductase, but we're not quite sure how it works in sickle cell disease. We know, though, that hydroxyurea increases the amount of fetal hemoglobin levels, okay? It's with the sickled hemoglobin that we get them stuck in the small little vessels that causes our acute pain crises. It can cause acute chest syndrome, right? It's what causes the functional asplenia in a lot of my patients with sickle cell. By the time they get to 5 or 6, we can get the dactylitis, right? We can get the infarcts in our kidney and lead to microhematuria. So if I can convert more of my sickled hemoglobin to this hemoglobin F is pretty much resistant to sickling, right? It's not going to sickle, so it helps reduce the vaso-occlusion. So hydroxyurea can increase the amount of fetal hemoglobin in my blood, and now we have 100% of my red blood cells, right? Let's say in a patient with sickle cell disease, 97% of them are hemoglobin S, right? In a patient who's homozygous. If we give a hydroxyurea, maybe we can take that 97% and bring it down to like 80% and make a bigger population of the cells hemoglobin F, so we get less of that sickling. All right. Why is the MCV increase in this patient? Remember, I did my whole lecture on anemia, right? We can think about microcytic, normocytic, macrocytic. When I think about macrocytic, I can break it down into megaloblastic versus non-megaloblastic. Remember, my causes of non-megaloblastic macrocytic anemia are going to be things like liver disease, alcohol, reticulocytosis, and myelodysplasia. Okay, and then things that can cause megaloblastic macrocytic anemia would be things like B12 deficiency, folate deficiency, copper deficiency, and then marrow toxicity, right? And so like marrow toxicity could be secondary to hydroxyurea, drugs like hydroxyurea. They block DNA proliferation, right? Because we're stopping ribonucleotide reductase, which is a really important enzyme in the production of my DNA. So if we're stopping the production of DNA, it's really hard for our cells to make new cells. And think about how often we're turning over red blood cells. In those cases, right, my red blood cells are just going to pump out, my bone marrow is going to pump out as many reticulocytes as we can to try to get out enough red blood cells to keep them in the circulation. The reticulocytes are bigger than my normal red blood cell size, so it leads to an increase in the MCV. We can also see the hypersegmented neutrophils, because when we mess with the DNA, it messes with the neutrophil, or with the nucleus of the cell compared to the cytoplasm, and we can get these really abnormal hypersegmented neutrophils. Okay, we gave the patient folic acid to prevent folic acid deficiency. Because when we're turning over our cells more often, my cells have to use a lot of folate, so we have to make sure we supplement with folate. So again, hydroxyurea, it's a ribonucleotide reductase inhibitor. It is first line for leukostasis. We're going to think about leukostasis when we get an individual who has a white blood cell count over 100,000. They have over 20% myeloblast, bone marrow biopsy, if we can see that, if we have that information. But over 100,000 white blood cells, diffuse bilateral interstitial infiltrates, hypoxemia, confusion, neurological deficits, headache. Okay, we're going to start hydroxyurea without thinking twice. If the hydroxyurea doesn't work, then we can try leukapheresis. We can also use hydroxyurea in sickle cell disease to convert more hemoglobin S to hemoglobin F to prevent the sickling and stop the vaso-occlusion. Another place we can use hydroxyurea is in polycythemia vera. I'm going to do a whole lecture on my myeloproliferative diseases, PCV, essential thrombocythemia, and myelofibrosis. Those are three of my favorite diseases. We love to talk about the V617F JAK2 mutation, right? 95% of patients with polycythemia vera have that mutation, and about 50% of patients with myelofibrosis and 50% of essential thrombocythemia also have that mutation. So that lecture will be coming. This was a relatively quick one. Hopefully that helped explain a quite complicated and tricky topic. It really tripped up a lot of students. So hopefully this helped explain that, and you'll get it right when you see it on a board exam, or you'll get it right when you're on the wards, if you ever come across this. If you have any questions, reach out. Otherwise, until next time.